Well, dear students, we will be discussing drug distribution today, and it's very important, especially in the drug pharmacological response of the drug is concerned. So these are our objectives, and let me proceed to the. What is drug distribution? Drug distribution is the process by which the drug reversibly, I'm using the word reversibly, leaves the bloodstream, meaning going to the interstitial tissues and then goes to the cell, passing the cell membrane and then reach the intracellular. So the intracellular fluid volume is 27 liters, and this is 12 liters, and this is on average 3 to 4 liters. Keep in mind these points, and keep in mind this is one compartment, especially here if we draw it for you. There is the membrane of the capillaries, you see membrane of capillaries, and similarly the membrane of the cells. This is intracellular, so this is the membrane of the cells. This is the cell membrane as well. This is cell membrane. So a drug should be enough competent to pass through this capillary membrane. For example, drug is here, and once drug is here, it has to pass through this capillary membrane. So now let's see. It tells you that the drugs reversibly goes from blood to tissues. This is tissues, and from tissues it goes to the blood. So this is a reversible phenomena. Keep in mind. And then what are the factors affecting? So the blood flow, of course, to the organ, capillary permeability, as we said, and then chemical nature of the drug, whether it is lipid soluble or water soluble, lipid soluble or water soluble. So this is also going to affect. This is also going to affect the drug in the binding to the plasma protein in the blood, albumin, and so many other plasma protein, lipoproteins. You see degree of binding to the tissues when it reaches the tissues, and some other factors like drug-disease interaction. You think that when drug is reaching the blood, so from blood, when it reaches the blood, you see it is circulated very fast, instantaneously, reaches the brain very fast, reaching the heart very fast, and reaching the kidney very fast. However, there is low blood flow to the skin and some adipose tissue, you see, that is a bit slow, and the penetration into these tissue is dependent upon the solubility of the drug. And once a drug comes, for example, a drug is here, it comes and penetrates in these adipose tissue, and if the concentration here is very high, so once it is eliminated going out from the body, if it is eliminated going out from the body by the kidney route, then what is important? Important is that where the concentration is high, so then it will be coming out into the blood from that region. So this is a very technical point to understand. In certain cases, the drugs may go and concentrate in certain tissues, like here adipose tissue, if this drug is highly lipophilic drug. So what will happen? Lipophilic drug. What will happen? Here the drug will accumulate, and this is called as redistribution of drug. And this phenomena is very important, especially when for the anesthetic purposes, when you use thiopentol and use propofol. So thiopentol is much more accumulated here, like in the tissues, not only in the adipose but other tissues, muscles, and so what will happen? The recovery will be prolonged, and that is why propofol is a new anesthetic drug where the recovery is very fast and it's very smooth. So thus the distribution of drug is affected by a main factor, that is the blood flow, and the redistribution is another technical phenomena. The second point that affects is the capillary permeability. Remember, the capillaries of the brain are not fenestrated, but that is astrocytes are there, and the complete basal membrane is here, you see, and this basal membrane is there, so the drug cannot go out and this gives you the concept of blood-brain barrier. Whereas in case of hydrophilic drugs, it passes a drug that oozes out through this pores. You see these pores, it oozes out and distributed. So these are called fenestrated capillary, and these fenestrated capillary exist liver and liver-like that allow species of hydrophilic molecules and easily that passes out and distributed into the tissues. However, there are continuous capillaries like in the brain, and only lipophilic can go out from these blood, and this gives you the concept of blood-brain barrier. So the third agent is the chemical nature of the drug that affects the distribution. So lipophilic drugs, when a like dissolves in likes, and the lipophilic drug will cross the cell membrane, and that is easily, which has a phospholipid layer, and the hydrophilic will have either a positive or negative charge, and they will penetrate to the fenestrated to the pores that is in the fenestrated capillaries. And molecular weight of the drug is also going to affect. A high molecular weight cannot cross these pores through this penetration, and that means facilitated diffusion as well. And the degree of ionization also affect the distribution of drug. Thus, these are the points that affect the distribution, which can be attributed to the chemical nature of the drugs. The other factor that affect the distribution is binding of drugs to plasma protein, and these are plasma protein. These grays are plasma protein, you see, and this blue is free drug. This is free drug, and this is the free drug that give you the pharmacological response effects. And you see, there are four types of proteins. You see, albumin, alpha acid glycoprotein, beta globulin, and lipoprotein. Albumin attached with the acidic drugs, with the basic drugs alpha 1 acid glycoprotein attached, and beta globulin binds to thyroxine like hormone and some sex hormones, whereas some other basic drugs are attached with lipoproteins. And what are lipoproteins? The lipids plus protein combined. So these protein plays a vital roles in the pharmacological response of the drug. So what is important? Now the important is that the attachment and the binding of protein drugs, and this bindings, you see, a drug is a bind to protein, how it will behave, and when it is free, how it will behave. A free can easily diffuse, it can be pharmacological activities can be attributed to this, meaning the activity of a drug is due to this active drug, free drug, and the metabolized and excretion is there in case of free drug. Whereas plasma protein drug is when attached with the plasma protein, the drug, so then it is not subject to metabolize, and half-life inside the body is increased. Now, significance of increased binding of drugs to plasma protein. What is its significance? The most important significance of this drug is that it slows the drug metabolism, and metabolism happens in liver. Thus, elimination from the body is prolonged. Distribution of the drugs to tissue is decreased. If it is more bind, this is a blood vessel, and the drug is now this is bounded drug, you know, and this is the plasma protein, you see, and the unbound drug is here. It is the unbound drug that give you effects. So if pharmacological effects are because of this, so if it is more bounded to this protein, so less drug will be available, and the distribution will reach to the tissue will be less. The amount reaching the tissue will be less, and the pharmacological response will be less. And another technical point is the computation. If computation is there, one drug is going to displace the other drug, then it can create problem. And one drug comes and attaches with other drug, and then the other drug is displaced, so the plasma level of free drug will be increased, and that will produce the toxicology effect of the drug. So example of this is, for example, when you prescribe sulfonamides to neonates. So in case of neonatal jaundice, the prebilirubin level will be increased, and when the prebilirubin level is increased, so the patient, the neonates will develop a case of hyperbilirubinemia, The anemia means the increased level of bilirubin is increased in the blood, and this will give you cardiac arrest, and that response is called medically in the children that they are lethargic, it will not, it will be drowsy, feeding phenomena will be affected, there may be fever as well, high-pitched cry will be there. So look how important is plasma protein binding in the clinical significance and how important this is in the neonate. Now, this free drug is available, and in case of dialysis of a certain drug which are more plasma protein drugs and poisoning has happened, so if you have to repeat the cycle so many times as compared to other drug which is less plasma protein binding. So this is the significance of the plasma protein binding when you will be using it clinically. Then the free drug level may be decreased due to significant plasma protein binding, and thus the therapeutic activity is also decreased. There is another condition, effect of the disease on protein binding and metabolism. Disease, for example, is chronic renal failure, there is hypoalbuminemia, you see, and then in this case, you see the metabolism of other drugs are affected. For example, you give phenytoin, so phenytoin toxicity is increased. There is a chronic liver disease, and when there is a chronic liver disease and like hypoalbuminemia is there and bilirubin is there, so you see, so the bilirubin level will be increased, and this bilirubin level is increasing in especially in neonates. That can create problem for you, as I discussed in the previous slide. But remember, when you prescribe diazepam to the phenytoin along with phenytoin, so the diazepam will involve the cytochrome P450 enzyme. We will study this in metabolism, but this is an example. And what will happen? The phenytoin toxicity is increased. So if I write for you, for example, this is liver, and in the liver there are enzymes cytochrome P450. This is enzymes, and this helps. For example, this drug is coming and it is metabolized here. You will study this in metabolism. So once it is metabolized, and then it becomes polar, and then it is excreted in the urine. So you will study excretion also there. So excretion of drug is there. So what happens when phenytoin plus diazepam is given? You see, diazepam is a drug. So what happens? Phenytoin is metabolized in the liver, and you see these enzymes. Now this cytochrome P50 enzyme will now metabolize this. When the metabolism of this will happen, so what it will does? So what will happen? The phenytoin metabolism is slowed. It is slowed down. Why slow down? Because the phenytoin metabolism is slowed down because the cytochrome P450 enzyme is engaged with diazepam. So this is how diazepam and phenytoin, when given together, will affect the pharmacological and the toxicological response of a drug. This is called as drug-drug interaction. So plasma protein binding of drug and its metabolism also play a vital role. There may be, for example, if you give furosemide, increases, so the drug that increasing from 2 to 6%, and the phenytoin is from 9 to 19%, that, and digoxin from 75 to 82%, the free level is increased. And similarly, the ferritin blood level are increased from 35 to 70%. And you know why? Because one drug interfere in the metabolism with other. You will study this in metabolism, but this is a technical point to remember how it's going to affect these factors are involved in the pharmacological response. Competition for protein binding between drugs. You see, this is one class. Class one drug are those where the number of drug molecule dose administered is less than the number of plasma protein, so the ratio is low. And class 2 are those where the dose administered that is greater than the capacity ratio, so the value will be high. And now when one class this is combined in the presence of this class 2 drugs, so what will be the effect? This class 2 drugs will dislodge this free level of this drug class 1 class. So what will happen? The free level of this class 1 drug will be increased, and when its level are increased, this will give you more pharmacological response, more pharmacological response of drug, and sometimes it will give you toxicity of drugs. So therefore, this competition phenomenon of plasma protein binding is very important in the concept of drug-drug interaction. And when warfarin is a class 1 drug, this is an example given together with class 2 drug sulfonamide. So what will happen? The free level of warfarin will be increased and tendency toward the bleeding will be increased. Therefore, one should be quite careful when prescribing class 1 drug with the class 2 drug so far plasma protein binding of drug context is concerned. So the factor that increasing the risk of adverse drug reaction, you see high volume of distribution, and then the therapeutic index. Therapeutic index mean LD50 divided by ED50. LD50 mean lethal dose 50. Lethal, L stand for lethal. Lethal mean killing. That will kill the 50% of experimental animals. ED50 mean effective dose, that will give 50% pharmacological response in the experimental animals. So those drugs which has low ratio mean they are very toxic drugs. You consider this, the drugs that have very toxic, that are very toxic. Then the elimination, it plays a vital role, the plasma protein binding, and also competition, especially when they are attached with the tissues, and in displacing the drug is given at higher doses. Displacement means removal. So when the drug is attached to reaching the tissues, you see, I have given you a concept in the class that when you take a drug, you see, from the stomach, it goes, it is absorbed, passing through the liver, and it reaching the blood, you see. So once it reaches the blood, so the drug is now in the blood, and from the drug in the blood, it will reach the tissues. It will reach the tissue. How? Through the blood capillaries and blood supply. And you know, if you recall my lecture, I have given you that there is some cellular membrane. This is cell membranes, and you see here is the 3-liter volume, and here we use the intercellular space. We use that there are 12 liters. And the intracellular, you see, intracellular, that is 27 liters, and clubbing all these together, it will give you 42 liters. So here is a membrane, you see. So the thickness of this membrane and the solubility of drug, mean the chemical nature of drug, is going to affect the absorption and ultimate plasma level of drugs, you see, and then reaching the tissues. This is very important. And the permeability of the drug into the crossing the cell membrane, not only of the cell but also the permeability, mean the membrane of the capillary. So thus the nature of the drug is going to affect. So what is important in this case? Important is that it should have a balanced pKa values so far absorption of drugs and distribution of drug is concerned. So the drug will come from the blood, reaching the tissue through the capillary, you see, blood supply, and it has to cross the lipid membrane. So what is important in this case is when this drug is reached, so it will attach with the tissues, you see, and with cells. So lead go and attach with kidney cells, iodides, that is in thyroid cells, arsenics will go and attach with skin and hair. And what will happen? Chloroquine will go and attach with liver cells, hepatocytes. Therefore, jaundice appears with this, and digoxin is going to affect the muscle, and it needs a high volume of distribution. So, what is important of the binding of drug to tissues? Already we talked about protein. Now we are talking about the drug to cells and tissue. In case of tissues, so once it comes and attached within the tissue, then from the tissues it will go to the blood again, remember, and then it will go to the blood. There is a reversible phenomena is there. So if it is more bounded with plasma tissues, with the tissues, protein. So what will happen? The half-life will be increased. It will take more time to be going out from the body. And in competition, we discussed in the previous slide, you see with class 1 and class 2. So one drug competes with the other, and this can create problem, increasing the one drug free level, and toxicity is then observed. So, for example, your patient is taking chloroquine, and chloroquine goes and attached and produces some retinal damages. You see, it is typical like bull's-like eye. It's a head you see, and you see this bull's eye. It is one of the most adverse effects due to toxicity of chloroquine when it goes and attach with the cells and tissues of this retina at the level of eye. So sometimes drug goes and sit down, and binding of drug and distribution of drug in certain tissue is it much more, it can go to leads to toxicological manifestations of drug. So other factors are maybe the drug disease interaction, edema is there, absorption will not be complete, amount in drug will not reach pregnancy, there is hemodilution, and some body fats you need, the body mass index is also there, and at the same time you see ion trapping phenomena is also there, and regional differences in the pH, and then the transport system that exists for the drugs. So all these things affects the distribution of drugs. Some special organs we are going to discuss. Now that special organ like brain, in the brain capillary you see there is no penetration, so there is a basement membrane, and this basement membrane is allowing only lipid soluble drug to pass through, and the ionized drug cannot pass through, and then active transport system is there and it will pass. So in case of if inflammation is there due to stress or for somehow reason inflammation, so the permeability is increased, and then the drug penetration may be increased. So keep in mind, if you have a patient with stress, his metabolism is no longer, and then the penetration of the drug or the distribution of drug to tissue may be changed, and this changing in the distribution of drug is going to change in the pharmacological response. So that is why we are going to teach you that how drug distribution is important so far pharmacological response of the drug is concerned. Placental, you see, in pregnancy, we have told you there are certain drugs which can cross the placental barrier, that and the milk plasma ratio we discussed that, you see. So molecules which is more than 700 Daltons, or they can be passed through the active transport phenomena. Lipophilic can pass only, can go to the fat and adipose tissues and cross the blood-brain barrier, you see, and weak basic drugs can, for example, from the mama it goes to the fetus, you see. So fetus has where the pH of this particular baby fluid is 7.3. So a drug which are very basic will tend toward will go and deposit in the fetus, and thus the more harmful effects are there, because it can easily cross the weak bases, can easily cross the placental barrier, and thus the teratogenic effect may be there. So another some case of testes, because it is one of the vital organ, and this testes you see it may lead to the infertility as well. So lipophilic drug can easily pass the testes, and the hydrophilic you need a transporter to transport. In syncytial cases, efflux transporter are also there. If it reaches the blood, the tissue, it is effluxed out from the tissue, and you sometimes the therapy or the drug response is not there. Now, fluids compartment. Keep in mind that how much fluids are there, as I discussed: plasma, interstitial phase, intracellular space, and you can take all these three combined. We will take all these cases one by one. But why we study this in the patterns of distribution. So regarding the patterns of distribution, we will take all these things one by one, like plasma only, plasma, interstitial fluid, and all these fluids together, and this will give you an example of that how drugs. In case of plasma compartment only, which it means the drug is still in the capillary, the drug is still in the capillaries, and And remember, the capillary membrane, it cannot pass the capillary membrane, so it remains only confined to this plasma. Therefore, we consider that the plasma volume of distribution for a drug is usually 3 to 4 liters. How? Because on average, for a drug volume of distribution is this. So if we calculate the volume of distribution liter per kg, so an average adult, one adult has a weight of 70 kg, so 4 liters divided by 70 kg, it will give you these values. Now, high molecular weight compound cannot cross this, and it is applied to this phenomenon is applied to those drugs. In case of the distribution pattern for the drugs with which can pass through the blood capillaries, it can pass through the blood capillaries. Remember, the drugs that can pass through the blood capillaries. Here we are considering this, but cannot pass this because there is extracellular space now, but cannot go and fill the cells. These are cells. They can pass the membrane of these blood capillaries, but cannot cross this to go inside the cell. This is another condition, and in this case, this interstitial volume we will consider, because the drug crossed here, is reached here, but it is not here. It is not inside the cell. It is not inside the cell now. So the drug is here, here, and here. So we will take 3 liter plus 12 liter. You see, 3 plus 12, and we will calculate this, the volume of distribution. And the example for this class is newstigmine, mannitol, and streptomycin. When we are going to take another total body water, mean that the drugs now cross the plasma, you see, and the plasma, it crossed it reached the interstitial space, now it is here, and then this drug has crossed this cell membrane of the cell, and now it is inside the cell as well. So what happens here, we will take all these points together, and 15 liter plus, you see, it will give you 42 liters, and this 42 liters mean this concept applies to which class of drugs? This applies to drugs which cross here, mean the capillary permeability is there, and the cell membrane and reach and cross the cell membrane as well. So this concept is total body water concept is applied to those drugs that can easily go inside the drug. And in this case, the volume of distribution calculated is 42 liter total. So ethanol, diazepam, and phenytoin, these are the drugs that requires high volume of distribution of drugs. And if we take the total body water plus specifically bound tissues or fetus, you see, like that. So in this case, we think that the drug goes from the blood, it goes to the tissues, okay, the drug reaches the tissues, and from tissues, keep in mind, dear student, it will go to the blood again. So there is a balance phenomena. But if it goes to the blood again, so it means if it is strictly bound to these tissues, mean the protein. This is here. What will happen? It will create problem in shape of what? It means it requires more circulation. It requires what? More circulation. Just to understand. Because once it is come here, then it goes again. This is once. Second time it will do again, and this is second time and third time. So it means more circulation is required, through which, so that sufficient amount of plasma or water molecule, water is going to remove this drug from tissues to the plasma. You see, so this concept is for certain drugs which needs high volume of distribution. Chloroquine, look at this chloroquine, 13,000 liter it requires. We cannot put 13,000 liter in human beings, and 1,500 liters for digoxin, or for amiodarone it is 4,500 liter. But we say that this process shall be so much repeated so that to dislodge the drug from the tissue to the plasma, or from plasma to the tissue. Thus, volume of distribution is usually an apparent volume that is required to distribute a drug from the plasma to the tissue. So in this case, if this amount of drug is given, the plasma concentration is this, so the formula for the volume of distribution is like this, and it is the apparent volume. Apparent volume means from the blood it goes to tissues, in plum tissues, it goes to blood, and it requires many cycles, you see, to clear the drug or to reach the drug into the tissue side from the plasma. So it is our apparent volume. It assumes that the drug is eventually evenly distributed while the drug binds to the cellular components like lipids, protein, and other factors. Thus volume of distribution play a vital role, and those drugs which require large volume of distribution requires more time to reach the plasma drug concentration at the target, which will give you the pharmacological response. So if I write for you, this is the drug, your patient has taken this drug A, and after some time the absorption is there and its plasma level concentration is like this. So what will happen, for example, this is absorption is there and the concentration is C is there. So the volume of distribution can be calculated by this formula. And if we apply this formula, you see, so if you give a drug and that drug is A amount 1000 milligram and the concentration of the drug is C is like this. So putting the value in the formula, you will get the 2.9 liter per kg, the volume of distribution for this drug A. Do you think that this volume is true or apparent? No, because 200 liter of body fluid is required to carry this drug A from the blood. This drug A is carried to the tissues. I will write here, is carried to the tissues, and to carry this drug A to the tissues for a pharmacological response, it requires 200 liter, but there is no 200 liter volume inside our human body. As we said, 3 plus 12 plus 27, it's got 42 and hardly 44, 45, yes. So it is the apparent volume of distribution. Now, the importance of volume of distribution is that, and studying this pattern, it will help you adjustment the maintenance dose, the dose of a drug, to targeting the pharmacological response of a drug, and it helps you in calculating the plasma concentration of a drug. It calculates in the loading dose through this formula. It also helps in the dialysis. For example, if poisoning is there and you want to wash the body with dialysis, so those drugs which are more plasma protein bounded requires much more cycle of dialysis. And in case of diseases, you see the volume of distribution that changes, and how it's going to affect. Then it is going to affect the half-life of the drug as well. So the half-life of the drug is affected, and it can be calculated with the help of volume of distribution. Why? Because half-life, you see, is calculated while putting the volume of distribution value in this formula, and if you know the clearance of a drug. Thus, volume of distribution is very important in targeting the loading dose, targeting the calculating the half-life of a drug, and if the patient is in state of other disease, drug-disease interaction, so you will calculate the accurate dose for those patients. Thank you very much.